You, ma'am.
Thank you very much. And I think this is an interesting topic for two reasons. One, we are all increasingly using AI in our daily lives, whether we realize it or not. Even when you use Google Maps to go somewhere and it tells you where the traffic is heavy, and you take an alternative route or it plots an alternative route for you, there is an element of AI involved in that. But two, medicine is going in this general direction of increasingly incorporating AI, and I think we need a degree of familiarity with this to be able to incorporate it into our daily practice. So one aspect of it, remember when Dr. Samit Ghoshal was speaking, he said that he used ChatGPT to do some of the diagrams in his talk. He showed you one particular one. Well, I can tell you, I'm doing a talk later, and actually my use of AI, that talk is almost all 80% done through AI. So hall be at 12:45, plugging my own talk. So the reality of diabetes care and why diabetes is perhaps particularly suited to AI is because it has a high prevalence. There is a significant economic burden when you have diabetes, and the mortality and morbidity in diabetes highly avoidable if only it was caught and treated in time. Now, if only it was caught and treated in time is the key, because obviously there is a, I can't see the screen when you put it there. There is a shortage of specialists, and there is an uneven distribution of resources. And then the patients, it's a lifelong condition. The low adherence is not only a patient factor, but it's a systemic factor, because we are not able to support them to the extent required for them to self-manage their condition. So AI in this setting gives us an opportunity to improve diabetes care. Now, where all can we incorporate AI? We can incorporate AI especially in those areas where we face challenges when we do face-to-face medical practice. So we know diabetes is highly prevalent. We also know that 50% of our population is undiagnosed. Why? Because we don't have the resources to screen our entire population and catch them early. Once we screen and treat, we have patients sometimes that turn up once a year. Face-to-face consultations are resource intensive and cost intensive. So in the follow-up and screening and management of complications, if we can bring in AI, that's an additional role. Diabetes frequently integrates care across specialties. So they may be seeing a renal specialist, a cardiologist, me, you, a podiatrist, a dietitian. How do we integrate care across all these specialties and make sure that we are all doing with whatever we do with the patient in the center of this? Again, AI can help. And above and over all of this, AI can actually help give the patient autonomy to be involved in their diabetes care and to self-manage to a huge extent. So broadly speaking, where can we use AI? We can use AI in the prediction and prevention of diabetes per se. I'm not talking about complications. So how do we look at prediction of diabetes? Now, in this room, we have authors who have given us risk scores for diabetes management and who are co-authors on several papers. So traditionally, we looked at a few factors, and then we did multiple logistic regression analysis or other statistical manipulations to then see which factors maybe give us the highest yield. But then we were left with maybe a handful of factors, most of them again centered around blood glucose measurement to confirm the diagnosis. Well, if you look at large data sets, so let's take the insurance data sets or the general practice data sets where people use EMR or the data is digitalized. Then looking across these large data sets, AI has actually developed prediction models where you can predict diabetes with more than an 80% accuracy 5 years before the onset of diabetes. So if we only had data sets across our population, and this is one of the biases and weaknesses of AI in India, if we had data sets across our population, it would allow us to look at factors that we can identify 5-10 years back and then start modifying. That is the second role. We can manage and modify the risk factors. If we can identify these specific factors, we can work with AI to see which of them give us the best bang for our buck, if you will, to concentrate our resources on to modify the risk factors for diabetes. The second thing is in screening. Now, if you look at screening, all of diabetes screening in India involves Mohammed to mountain or mountain to Mohammed. There has to be some meeting of blood and equipment. So you've got to go take blood, patient has to come somewhere to give blood, whatever it is centered around having a blood glucose reading. Well, there are now models of prediction of diabetes which can give you screening predictions of diabetes with an accuracy, sensitivity, specificity of over 90% that don't involve a blood test. You can predict that this patient is, out of the 100 people in this room, if we run this algorithm, I can probably tell you which 5 of you need to go get tested for diabetes without actually needing to look at even your blood glucose values. So there's a high degree of accuracy now in being able to screen for diabetes across population levels without actually doing a blood glucose test. Then it helps in classification of diabetes based on existing clinical guidelines. But more importantly, remember we have the Alquist data set, and in Chennai we have our Dr. Mohan's data set. It allows you to redefine, reclassify diabetes with the view of personalizing diabetes management. So AI actually allows you to do cluster analysis. And you can only do these kind of cluster analysis across large data sets that have hundreds of thousands of patients, and you cannot undertake manual analysis of such data sets. So here AI gives you an edge where you can go out to a population level, go out to an insurance database, go out to a GP practice database, national databases, and then look at precise classification of diabetes. And then we come to management of diabetes. AI can help with health education. So there is this model where people diagnosed with diabetes were basically given an AI program to look at. And they went through education. The AI model accurately identified their gaps in their knowledge of diabetes and then improved their knowledge, where at 12 weeks after that, there was actually an improvement in A1C. AI has also been developed in terms of blood glucose monitoring. Blood glucose, we'll go step by step. Health, medical nutrition therapy. I'm lucky enough to have a dietitian in my clinic. Not everyone does. Especially if you're practicing in a limited resource setting, tier 2, tier 3, wherever you are, you may or may not be able to give a personalized nutrition plan to a patient. Well, I have patients with quirks, and just as an experiment, I did this. I started using ChatGPT to say, give me a 1200 calorie vegetarian diet plan including X, Y, and Z, whatever the patient likes. And I will say, give me a week's worth of breakfast, lunch, and dinner. And I tell you, it's beautiful. And then you can go one step further. I can say, using X, Y, and Z, give me breakfast recipes for a week. So it gives you ideas and recipes. So once it gives me the ideas, I can just say, give me recipes for all these ideas. And I can print out a diet plan. I can just PDF it and send it to the patient in 1 minute flat. So if I don't have a dietitian in my clinic, it is no longer a loss. I don't need to pay for a dietitian anymore. I can ask for low salt diets. I can ask for salt restricted. I can say 3.5 grams, and it will tell me exactly added and innate. And I can use it to manipulate any amount of fat, any amount of protein. So AI is actually quite good when you want to personalize something like this. Physical therapy, again, is something that is difficult to sustain. If you start going to the gym, you get bored. You do 6 weeks, you do 10 weeks, then you stop. You can actually use AI, sorry, how am I doing for, okay, I'm okay for time. You can actually use AI to personalize your physical. Now, I'm only restricting myself to talking about diabetes-related medical AI because that's the brief of this talk. If I were to go into just use of AI in medicine in general, that's a whole different talk, but I'm going specifically with diabetes here. I can ask for it to say, give me 5 strength training exercises for somebody with hip arthritis who's 70 years old and has sarcopenia. It does. I can say low back pain, core strengthening exercises for a 55-year-old obese woman with a BMI and no exercise. And I can tell it, give me graduated exercise plan that they can increase every 4 weeks. And it does. And this is what I'm doing in clinic now, personalizing exercise plans and nutrition plans and giving it out to my patients. It can allow you to predict. The blood glucose monitoring and prediction is better in the short term than in the longer term. And we see this when you get a patient to wear a CGMS. The algorithms are very good at predicting direction of travel. It's going up, it's going down, 1 arrow, 2 arrows, it's going up at this rate, that rate. And it can predict hypoglycemia and hyperglycemia up to an hour very accurately, less so when it gets beyond that hour. But these algorithms are in development so that you can use it not only to predict, but then to suggest alterations of diet, of activity, of insulin to change this. Drug therapy. I'm going to personalize drug therapy is at a nascent stage, but AI is being used now to, one, develop drugs, two, to then personalize those drugs to the individual. But more immediately in diabetes, insulin dose titration. So there is this algorithm that allows you, there is a Chinese study, premix insulin. You can actually put the patient on a premix insulin and plug them into this particular program, and based on their blood glucose readings, the algorithm allows the patient to self-titrate, and at 12 weeks, the outcomes with A1C are better than if they were done through a clinic or through a nurse support system. We use these MyCoach apps and other apps for basal insulin titration already. So we know that there are algorithms that work for insulin titration. Behavioral coaching and support, it's really good where you have specific support requirements for depression, for other conditions where chatbots can actually provide day-to-day support where you can't access day-to-day personalized health coach or guidance counselor support. And remote monitoring and telemedicine, again, I come back to CGMS. I have a dashboard. I see both versions of the CGMS that I use. I just open it up, I look at it, and then I send my patients instructions on what to do with their insulins. So these are very easy to manage. Then we come to complications. The most common complication that it's used for screening for is diabetic retinopathy, but you can also use it for foot. You can do foot screening, feed in the image, and then it will tell you how at risk the foot is. You can use it for diabetic foot ulcers, where you upload an image and it will tell you what kind of an ulcer and the treatment options. You can screen and evaluate diabetic complications, again, for retinopathy, the most common one that it's being used for, but foot also. But equally, now retinal screening is being used to predict the development of diabetes complications, including nephropathy and cardiovascular morbidity. So by looking at the eye, you can write their future. So look at my palm, tell me my future. Look at your eye, I'll tell you your future. That's the direction now. So if you look at opportunities in clinical practice, all of what I've told you can translate into clinical practice, but most importantly, there are 4 P's. Number 1, penetration. If you look at the use of AI, as long as you have some kind of internet connectivity, you can actually use devices to go out into remote areas to talk about prevention, screening, diagnosis, all of what I've talked about. Number 2, you can talk about prevention. So penetration out to areas where maybe doctor numbers are fewer, healthcare professional numbers are fewer. Then you can put in the prevention, screening, and all the other measures. Number 3, personalization. For people in clinic sitting in front of you, with the integration of genomics, metabolomics, and all the other omics, you will soon be able to personalize their prescription. Okay, for you an SU would work better, for you a DPP-4 would work better, right? And then there is the next step, precision therapy, precision diabetes medication. So once you have genomics and metabolomics coming into play, you can actually use your AI engine to then tailor it not to your population, but to you, just for you, what works best for you. So we're going down this path of increasingly improving your therapy for these patients. However, challenges, I'll come to it a bit later, but especially in our population, available of technology and available of data that is particular to our particular data set. Then, in clinical practice, self-management tools, I've already referred to insulin dose titration, closed-loop insulin algorithm. So, for example, the Medtronic 780G with the sensor works as a closed loop, and it is AI algorithms that are iterative and self-learning. So they become individual to the person using that particular pump and that particular CGMS, where you put in a basic algorithm, but then the algorithm learns to teach itself. So we can talk about machine learning. Some of it is supported, some of it is semi-supported, some of it is self-taught, and these algorithms are coming to the point where you keep feeding in data and they become more and more self-taught. Drug discovery and development, I've already said, if you know the target, and if you know the approximate kind of, the story of DPP-4 development before the era of AI is one where you literally knew a target and you looked for molecules that would fit that target. In this era of having these huge databases of molecules and targets. It's just fitting one to the other using AI. And then you can actually do the preliminary phase 1 studies with AI itself, looking at the potential effects and adverse effects. So a lot of drug development can happen in the AI world before it needs to come to us. Unfortunately, what are the challenges for us? Indian data, almost non-existent. Technology, the design is evolving, and if you go out to remoter places, then the technology you have might be very, very, very limited. Privacy concerns. On the one hand, I want a diabetes drug that is tailored to me alone. On the other hand, I don't want to put my data out there for every Tom, Dick and Harry to hack it. So it is a huge amount of data, your metabolic data, your genomic data that needs to go out, and commerce always works faster than science in these kind of scenarios where data regulation, data protection legislation hasn't really caught up with the amount of data that's out there, and therefore our laws and regulations really need to catch up. For Indians, the data bias is huge, barely any of our data. Then it's always overfitting. So when you have any data set, it's really important not to overfit it and not to really try and make it as dense and as terse as possible, because then you're losing the granularity and you're also losing a lot of data that will actually, the ROC curves, for example, might only be 0.8, but by the time you get it to 0.96 or something, you lose a lot of data that is useful for the larger population. Training is resource intensive. Any ML model that you want to train needs hundreds of thousands of data points to train and then to test on. And then the transfer of learning is limited. What has been trained on a Caucasian population may not apply to our Indian population. So lots of the challenges and difficulties, especially when we come to our Indian scenario. So to summarize, there is progress, there are huge opportunities. It's up to us to take up these challenges and build our data set in India that will help us do the best for our patients. Thank you very much.